Okay. So we will be discussing role of atezolizumab monotherapy in first line setting, and we have already seen Dr. Ashish Singh presenting to us the data which is available. Targeted therapies, we all know, have improved the survival in non-small cell lung cancer, and there is an unmet need for this kind of treatment in patients who have no actionable biomarker, and PDL1 positivity is now becoming a significant mark. First slide. So my question to Dr. Kumar is, what is your treatment of choice in patients with no actionable driver mutation?
A speaker. So, if the mutations are negative, then PDL1 expression becomes important biomarker to decide a first-line treatment. If it is high, we take a cutoff of 50%, but that's one of the cutoff we take it. It is high, then giving immunotherapy alone is something we choose. In case we also look for how is the tumor burden. If it is high, again that becomes one of those relative important factor. We again choose whom to give them only single agent immunotherapy or to combine. But below 50%, by and large, we combine with chemotherapy in this setting. And yes, we do have this again other option of combining with VEGF inhibitor also with chemotherapy and immunotherapy. But by and large, we don't use them so commonly. But this is the overall schema of things in case if the patient can afford all the options available.
If there are no mutations, do you use only immunotherapy in those kind of patients?
Yes, if I have a PDL1 expression of more than 50% and tumor volume being
No PDL1. It's PDL1 zero.
oh, then also yes, I do use I give that option, but telling the patients that the chances of benefit what he's going to get with them is going to be low, and if they understand that and they are willing, then yes, we do combine that with chemotherapy.
No, means nivolumab, ipilimumab.
Yes, that's a very important discussions, sir, you are bringing up, and that is one of those combination where you have more subgroup analysis, which suggests that if you have a PDL1 expression which is low or negative, and that shows that combination shows a bit more benefit than what we have seen otherwise with immunotherapy alone. But we do also have data for keynote 189 that combining with chemotherapy also gives a good result. But having said that, I do agree, if I have to tease it and then place this combination somewhere, this is one place where one can use this combination in that setting. So there is a merit to it, what you suggested, Dr. Jain.
Okay. Can we have the next slide, please? Dr. Ashish, what are your, how do you choose? Means whether you're going to do which platform investigations, like whether you will be doing an SP142, you will be doing a 22C3, or you will be doing a SP263, or you'll be sending it for Foundation 1, or you'll be doing selective markers. What are your parameters? Like, how do you choose?
So typically, sir, I prefer to go for a broad based NGS based testing, but we obviously understand that there are limitations sometimes in terms of the finances. So then limited lung cancer panel also is often, that is the bare minimum that I do for all my patients. And PDL1 usually is SP263 is the marker which is commonly done in the laboratories where we are associated with. So that's what practically happens. We obviously know that there are companion biomarkers for each drug, but that is typically what is not practiced in a community oncology. And usually SP263 is the one which rules the roost.
Okay. Dr. Rajit, anything different at your place?
So for practical reasons, it is all the same. But if we know that we are going to plan a particular IO drug, then it's better that if it's possible, we do use that platform. But if we are not sure, or we can use the platform interchangeably, but if we know that we are going to plan this particular regimen, then it's better to specify the type of PDL1 test.
It becomes very difficult what we are going to use. It all depends on, after the reports come, then we start thinking what we are going to use. So
Correct.
This is the biggest trouble with us. Like we order, we get, and then we start deciding. So we're not decided with what you are going to do, and
So
that is where
not in that way. Suppose we
platforms.
have the NGS report with us and that is showing no mutation, then we can decide whether we want to, what type of platform do we want to do. So if
Uh,
we have the NGS report with us, then we can separately order the PDL1.
do you consider TMB as an important marker for considering immunotherapy?
So it is an important marker, but as of now, I don't think that it should be used in clinical practice because the data is still evolving, and at least most of the clinicians, they are not comfortable using IO with the TMB report. So I don't think that it should be used as of now for deciding the treatment.
Yeah, I agree. The rule is very uncertain right now, though it may indicate in certain things we are taking it up, but for lung cancer, we should restrict ourselves. Next slide. Basically, if you look at all these are the markers available to us, but what we are using today is the PDL1 expression either on the tumor or the tumor microenvironment or the immune cells. So this is the only thing which is really helping us. We are not sure. Dr. Ashish, do you consider age as a factor for immunotherapy consideration?
Not really, sir. I think immunotherapy is something which is a pervasive and it probably could be given across the subgroup of patients. So, in fact, sometimes there are old moribund patients where chemotherapy may not be an option. That time, in fact, monotherapy with immuno, especially with the PDL1 positivity, could be a decent option. So, age is not a consideration for doing the biomarker analysis. And irrespective of the age, I think we all nowadays in our clinics do at least basic biomarker analysis, which is limited lung cancer panel with PDL1 testing.
Dr. Kaushal, do you think that your patients with smoking history, non-smoking history matters when it comes to immunotherapy?
Good evening. As of now, actually, we can consider IU in both the cases, either it's a smoker or non-smoker. I don't think so if there is any difference of the result point of view. So we can use it in either of the cases.
No, we can use it, but the results just presented by Ashish also showed that if patients are more than age 75, or if they are non-smoker, non-tobacco chewer, or non-tobacco users, then they were not good on the forest flood. They were actually falling on the other side towards the chemotherapy. So, Dr. Ashish Singh, do you want to add to this what you presented?
Sir, I think I'll agree with both of you. I mean, but what I would want is a little broader NGS panel in people who are younger and who are non-smokers, just so that I'm not missing maybe a better option. But if I have done a good NGS and PDL1 positive, just because he is not a smoker would not stop me from using this option.
Means, would you consider them for chemoimmunotherapy rather than immunotherapy alone? That is what is my next question.
Yes, sir. So adding chemo, whatever trial we have seen has definitely helped. In this more than 50%, we don't have data yet of chemoimmuno better than immuno alone. But but like as Dr. Kumar sir also has said, high disease burden, symptomatic patients, even the 9-LA like regimen, only 2 chemo and then stop the chemo after a response is a good option.
Okay, next slide. So, my question to Dr. Dattatreya, if there is a PDL1 high expression more than 50% in any of the tests, whichever is available, would you consider single agent immunotherapy or a combination with chemotherapy or only chemotherapy?
Without any doubt, sir, I would go with the first option of using a single agent immuno-oncology molecule. My practice more has been towards pembrolizumab, but having said that, I'm completely okay with atezolizumab also. So single agent IO is my treatment of choice when the PDL1 is high.
Okay, let's see the data, what comes up. Next slide. Next, can we have the next slide? So cancer immunotherapy offers a chemotherapy-free option to patients with non-small cell lung cancer. It provides treatment which is having an increased survival, reduced therapy-related toxicity when compared to standard of care. And this is something which is we have already seen that there is a 7 months advantage in this kind of patients. Next slide. So we have 4 trials which have shown that there is an improvement. The IM Power 110, the Keynote 024, the Keynote 042, and the Empower, the drug which is not available to us right now, Semiplib. So Semilimab, which is not available to us as of now. So let's look at these 4, which are actually the positive trials in this monotherapy cancer immunotherapy. Next slide. We have already seen this data from Dr. Ashish Singh, so we can go to the next slide. So there is a 7 months advantage, hazard ratio being 0.59 in this kind of group of atezolizumab, and definitely patients doing well even after 20 months. So you continue to see the graph moving away. Next slide. Yeah. Next. Okay. This is what I was trying to say, that if they have never used tobacco, then these are the patients who actually fall on towards the chemotherapy side. And if they are older patients, their hazard ratio was 1.04. So if you have an older patient, immunotherapy probably was not doing well for them. So rest everybody favored the immunotherapy arm. Next. Okay. So this is already discussed. There was a meaningful improvement in PFS in patients with atezolizumab, and this was definitely for the arms which were like hazard ratio was 0.63. The 12 months and 6 months both were improved progression-free survival in this particular arm, but this was not the primary thing when we were looking at the study. Next slide. Now my question to Dr. Kumar is like, what is the platform you are using at TMH? SP263, SP142, or you are using any of those?
Sir, we are using SP263 at this moment.
Okay. Is there a benefit of 142 compared to 263, because it will give you both the tumor as well as the immune cell expression?
I think so. You can have all the platform. We have not been able to get DACO, sir. So that's a challenge, that having all the antibodies, and so ultimately we end up having in most of the lab single antibody and single platform, and then we try to see how concordance rate has been, and that's what I think so. Ashish also tried to bring up that there is a good concordance, and before that there has been 2 study, not as a part of a randomized trial, as a part of study to see those different antibody and how they correlate good to each other, and looks like they correlate fairly well. Having said that, except SP142, which was an outlier, others they correlated very well to each other, and one can, again I repeat, I say that it can use it interchangeably. But having said that, if we can have a moon on my plate, I like to have it, but otherwise I will go by what is available. That is, I have a SP263, and I'll try to compare with this data what is available and use it in the clinic. And we do use it, not for this drug. Before that, we have been using a single agent immunotherapy based on the data available with SP263.
See, the thing is that if you have a high expression, whether it is with SP142, 22C3 or SP263, in all those cases, the outcome with atezolizumab when they compared was good. It was 20 months, 19.5 months, or 20.2 months. So it was doing well, and all those things had a concurrence. So if you have a high expression, atezolizumab can be used. When the expression is low, the difference is quite significant. So if you are using a single agent atezolizumab in a low expression, you may have to do an SP142 to find out if there are select patients who may be expressing on immune cells. So if it is high, and then there is no problem. If it is low, do not use interchangeably. If it is high, you can use it interchangeably. There is no problem. And almost 30% patients may fall apart. So there is a big number which actually falls apart. So only in high, you can use it. In low, do not use it. That's my suggestion. But anyway, we can take from the house if anybody has any different suggestions. Dr. Kaushal, Dr. Ashish, if you have anything to suggest, we can.
Can I make a quick comment, sir?
Dr. Minish, on one comment. Only thing is that it's not the question. The only problem will be the PAP program, what the company wants. So that is going to be the most difficult thing to. So if we have done a SP2 to the pembrolizumab for, then can we use that for that? Or vice versa, if you're going for adinolumab, and then usually the 142 people usually do not use that. So if it is been done from 2 to 3, whether that can be applicable for that or not. So that is going to be the question from the company side. If they are comfortable with that, and I think if there is a pathologist there is one of the study which is not a blueprint study, blueprint 2. That compared that SP223 and DACO kit, they have a good concurrence between these two. But 142 and the other have not a very good concurrence. So the 223 and the DACO kit has a good concurrence from that point of view.
No, I agree. That's what I'm saying. If there is a high expression, atezolizumab can be used at par. The outcome is same for all the 3 tests. But if it is not very high, not more than 50%, then do not use atezolizumab in those lower patients. So you may have to do an SP142 if you are specifically looking for atezolizumab. That's what I'm trying to say. Next slide.
So can I make a quick comment, sir?
Yeah, please.
So just coming back to the same question about monotherapy in first line, and we have all discussed about the discordance and concordance of the PD-L1 as a biomarker. Somehow in my clinic, I tend to use, even if for a high expressing PD-L1, I tend to use combo of chemo and immuno to start with, especially in a symptomatic patient, and then get the chemo out and then probably continue with IO.
No, there is nothing wrong. See, This is all about personal choices. So you can decide if that is comfortable for you and your patient is fit, why not? You are actually creating more antigenicity. So I agree. If the patient can tolerate it, you can go ahead. There's no such thing that you cannot use it. There are so many choices now.
Yes, sir.
Sir, there is one more thing that I would like to add. So in all these graphs, you can see that the graph, the curve separates after 4 to 6 months. So even if PD-L1 is more than 50%, I also think that the more rational combination is adding chemo plus IO. So that covers all the problem regarding the PD-L1 platform, regarding the age, regarding patient is smoker or non-smoker. And so that is a more rational approach for me also.
See, we are moving from gunshot to the more targeted. So that is a gunshot. You can take everything under it. You can give ABCP also then. So that's not an issue. When you have highly select population, and if you have selected it rightly, even a single agent can do magic. So you do not require too many agents to create a magic. So you need to really know that your patient is a tobacco user or not. That indicates that the tumor mutational burden is going to be high. Okay. So if a patient is non-smoker or non-this thing, there may be some mutations which have been missed.
Like the magic can happen after 2 to 3 months also. So if we
KRAS.
if we give chemotherapy, then after that magic can also happen.
No, that's true. But there can be other factors. KRAS can be there. There can be some which we may have missed out. So that may be the reason why patients do not respond. And they may be responding to your paclitaxel. KRAS may be working well with paclitaxel.
I think so. Organizers are getting a bit restless for timing.
Okay. I think we will go to the next slide. Okay, I just want to quickly come on to next. Can we skip this? We have already discussed this. I just want to highlight on one thing. When we compare IM power 110, the 024 and 042, the next slide. IM power 110 was standing out through the meta-analysis of network meta-analysis, and the thing was IM power 110 was having both squamous as well as adeno. It had some Asian population which was around 19%. The keynote 024 had 97%. So if you look at Asian kind of patients with liver metastasis, which was not included in 024, which was not included in 042. So if you have liver mets, if you have Asian, if your tobacco exposure is there or not there, if you are squamous or non-squamous, then, and if you look at the network meta-analysis of toxicity ratio, atezolizumab, we do not have time to cover up all those things, but then in those situations, we find that this drug is coming out quite good. Next few slides, we can just go through it quickly. Next. So this is something which we were discussing. The liver mets were not included in this. So the outcome was good in 0 to 4 because these patients had all high expression, male, more exposure of tobacco, which was less here, and liver mets were not there. Next slide. Next, we can skip this. Next, and this was the meta-analysis, which was showing that atezolizumab was significantly better. Cemiplimab was also good, but the toxicity of immune responses was very high in this particular population. Next slide. This drug is not available with us, but then if you look at the immune-related reactions to this drug, which was very high compared to atezolizumab, which was favoring into this meta-analysis. Next slide. See this, if you look at this right side, it is the immune-related adverse events, which were high in this particular study or the cemiplimab study. Otherwise, the drug was good. Atezolizumab was falling onto every time on the better side. Thank you. I think we have covered most of the points. If there are any questions from any of the participants, we can take that.